Hi, this is Dr. Howard Glazer speaking, and I'm glad you're joining me this evening. We're going to talk about going digitally, which is potentially a difficult decision that's made easy once you understand what we're talking about when it means to jump from traditional analog radiography into the wonderful world of digital radiography. Just a little bit about myself. I am a fellow and past president of the Academy of General Dentistry and a former assistant clinical professor in dentistry at the Albert Einstein College of Medicine. I lecture all over the world, predominantly United States and Canada, and I am thrilled that I've been asked to do this tonight. I also serve as an attending dentist at the Englewood Hospital and Medical Center in Englewood, New Jersey, and I do write a column every other month for Dental Economics magazine called I Have It, You Need It. I also serve on their editorial board, and I maintain a private general practice in Fort Lee, New Jersey. So tonight, I'd like to do a few things with you. I'd like to share a brief overview of present scanners. I'd like to discuss with you why digital versus analog, and is there one solution for everything? We'll talk about the advantages and disadvantages of sensors, the advantages and disadvantages of phosphor plates, the overall advantage to digital radiography, a little bit of statistical review, some references in literature, and we'll conclude with some final comments by me. And then I'd love to open it up for questions and answers. So I hope that you will stick with me, and we'll try and have some fun doing this. I want to thank Air Techniques certainly for making this possible tonight, and we will talk about digital radiography. First of all, as a preface, let me tell you that as a reviewer of new products, materials, and techniques, my mantra has always been to try and find things that are faster, easier, and better, not only for me as the doctor, but better for the patient, because it is the patient that is the ultimate end user. And lastly, we consider price. But when you're talking about price in digital radiography, there is no contest as far as I'm concerned. Digital radiography, I think in the long run, is more cost effective. Certainly there are no chemicals in the office. There's no waste disposal of those chemicals. There's no odors to the chemicals. And in today's world, we try to be rather chemical free wherever we can be. So I think it's a greener, healthier way to go when it comes to digital radiography. So right now in digital radiography, there are basically three different things that we can deal with. As you see on your screen, traditional analog film are those little squares that everybody's used to seeing. And then we have underneath that, you see the rigid sensors, and those are called direct digital CMOS or CCD sensors. And of course, we have phosphor plates, as you see here, which are quite flexible and very similar to analog film. And this is something that, having had the opportunity to play with both, I do have both in my office, but I tend to go more for digital radiography. Those are basically the kinds of apparatus that you use. PSP, or phosphor sensor plates, are also known as phosphor storage plates. These are photostimulable phosphor plates, and the best analogy to make is if you ever made a pinhole sun camera, you would understand it. So we're going to talk about dual digital or hybrid solution, meaning we're going to talk about direct sensors and indirect phosphor plates. In doing so, we have to understand that when it comes to processing a phosphor plate, you need to scan it. And all of these devices that you see before you are various types of scanners other than what Air Techniques makes. You have the Acteon PSPIX2, the Apixia one, the Carestream units are in the middle, the Sordex, the 3-disc Fire CR, and the Sirona IOX scan. And they're all good machines. However, when it comes to my choice, I tend to go with the ScanX system, and that is by Air Techniques. Why? Basically, it's it's peace of mind. It's fail-safe. It's built in. The units are solid. They have different modalities that you could use, such as you see on the left. The classic ScanX is right there, and this is a rather interesting device because if you know anything about this, you'll want to view the images. Well, it has a little screen so that you could readily view your images right on the unit. So it makes it possible for you to use the unit to view the X-ray without running back to your room to look at it on the big screen that you might have on the monitor with the patient. It also gives you the availability in this kind of a unit to process a panoramic film or a cephalometric film. So it works quite well in all different modalities. Then you have the classic unit immediately to the right, which is a very nice unit. It is also, it takes 4 films at a time to process. It too, as you notice by this barrel configuration on the top, that means it will handle a panoramic film or a cephalometric film. And let me comment about that for the moment, in that you do not have to have a digital panoramic machine to take a digital panoramic radiograph. Let me explain what I mean by that. For years, I've not had a digital panoramic machine, but I have used a panoramic machine that takes a conventional panoramic film. I then use, instead of the conventional film, I use a phosphor plate digital film. I expose that panoramic film and I process it in my ScanX, thereby creating a digital image that I can then manipulate on my own screen. So I've got a digital pan without having to buy a separate digital pan. As we move to the right on this, let me show you 2 other units. These next 2 units in the middle of your screen are really the same unit cut in half. And by that I mean it does not allow for cephalometric or panoramic films. The one in the middle of the screen that says ScanX intraoral has no view box, and the one to the right of it does have the view box. And both of those can work quite easily in your operatory, or I keep them all in what was a dark room with tanks at one point, now is a facility, just a dark room, and we process everything there. It's basically a storage room where we put this, and it's tied into my network. So it works quite well. The ScanX Duo, as you see to the right, is just a 2-film processor, and to the right of that you have 2 other very interesting machines. These are the ScanX Swift and the ScanX Swift with a view box on it. What these are basically designed are for pediatric use, geriatric use, where you may be only taking 1 film, but what I like to think of them as, we keep them in the treatment room wherein we do predominantly our endodontic therapy and oral surgery. And those are the 2 most common types of films that are single films that you will take, and they basically afford you instant gratification. So let's talk about this hybrid approach that I alluded to before. And the hybrid approach here means that you can certainly use a rigid sensor, as you see on the left, and for 100% of your images, or you can use, to the best of your potential, a combination of what you see on the right, which are the more flexible phosphor plates, and you will get perfection every time. I have used sensors on occasions, the rigid sensors on occasion. I tend to stick to the wireless version of phosphor plate, which they're all wireless because they're very much similar in handling and flexibility to conventional analog film. My problem with the rigid sensor is rigidity. It makes it uncomfortable in the mouth, and we'll talk more about that in a few minutes, but it also is wired, and this wire has to be hanging out, and it's very fragile sometimes at this juncture. and that could cause problems down the road. So there are plenty of good sensors on the market. The rigid sensors by Gendex, Dexis, XDR, RVG, they make great sensors. But if you notice when you compare them to conventional analog film, they're a little smaller, and so you're losing some of your capture area, and we'll go into that in more graphic detail in just a few moments. But there are some qualifying questions to remember when you're going to make that transition or think about that transition to going digital. Number one, as I already teased you with, if you own a film-based analog pan or Ceph machine, you can instantly convert that to digital by using phosphor plates and processing that in the ScanX Classic view or the ScanX Classic. If you own a wired or hard sensor, you've got to stop and think, are patients complaining about how hard it feels, how thick it is, how uncomfortable it is when you place it in their mouth? What do you do when you have a patient with mandibular tori that are prominent? How do you get that in comfortably for the patient? Or even a maxillary tori can be very disturbing to the patient when you try and place this hard, rigid sensor in their mouth. When it comes to pediatric patients, again, flexibility is key. And, you know, geriatric patients, and I've got to be careful when I refer to geriatric patients. As I always say, I'm 71 years old, and the closer I get to middle age, the further it's going to become. But pediatric patients and geriatric patients have a lot of the same problems. They have problems with dexterity. They have problems with holding something fast and easy in their mouth. They are more apt to be comfortable using something flexible like a conventional film, analog film, and that again is phosphor plate. And as I said before, you've got a large percentage of our population that have tori or maybe gaggers, or perhaps you're treating special needs patients. Those are something to consider. And to date, I have not seen any rigid sensor that can accomplish a occlusal film with adequate and full pictorial representation of what you want to see on an occlusal film. And the size 4 occlusal that they have, that Air Techniques has in the phosphor plates, is excellent for doing so. So let's talk about, you know, you probably never stop to think, but think about how many patients have a gag reflex, small mouths, or tori. In the age range of 41 to 50, you know, you get a large percentage that are having tori in there. So more than 60% report that at least 10% of the patients have problems, and a third of those patients report that greater than 20% of patients do have some sort of problems. Let me tell you, by the way, when we're talking about a gag reflex, something we've tried over the years, regardless of analog film, hard rigid sensor, or phosphor plate, I learned many years ago to do a temporal tap. When the film is placed, you quickly use your 3 middle fingers, tap the temporal region, and that disorients them or disorients their sense, and you can accomplish it. Most recently, I have found something even simpler. When the film is placed in the patient's mouth, simply ask them to raise their 2 feet several inches off the chair. For whatever reason, this works fantastic. Whether it's young, old, middle-aged, whatever, it works great. So getting back to the issue of gag reflex and small mouths and tori, digital radiography using a phosphor plate, certainly the way to go. Now, when it comes to taking the radiographs, most often those of us as practicing chairside dentists relegate that responsibility to either our hygienist or our assistant. And as you see here, 65.5% of hygienists are the ones that take them, and that's when it comes to full mouth series. But for signal radiographs, more often than not, it's our dental assistant, because we are taking that chair side. They are going to take that chair side. So on the number of images that you're taking on a daily basis, you are seeing this graph before you that shows few full mouth series are taken each day. It's more conventional that we take a recall series, which may be 4 bite wings, maybe it's 4 bite wings and some anterior periapicals. Those are the more common radiographs that we take on a daily basis. The number of times per day that images are retaken is actually quite interesting. You're getting 60% of offices do 2 or more retakes every day. 25% of the offices take 4 each day. Why are they taking this? Well, first of all, from a patient's perspective, that means they're exposed to more radiation. No, I don't know about you, but I get more and more patients that question why they have to do radiographs, period. They certainly want less radiographs, and by using digital radiography, you actually can shorten the radiographic exposure time, which is great. But the reason you're having to do retakes more often than not is because you haven't captured everything that you had hoped on the film. And part of that reason is because when you're using a rigid sensor, the capture area is reduced over a phosphor plate. So technique certainly comes into play, but we want to make sure we can have the largest capture area we can to ensure that we see the maximum amount of information when we're taking a radiograph. Most of us take our x-rays while seated. While standing. Very few people sit down and take an x-ray, in part because we generally leave the room when the x-ray is exposed. So having that immediately available, which is a big argument of those who sell and manufacture rigid sensors, in that you can see the image in as little as 2 seconds, some of them claim. And yes, that's very nice, but let me tell you something. When I'm doing a phosphor plate, I can get it in 6 to 7 seconds. Do you think I'm going to see 4 more patients that day because it was 2 seconds faster with digital? No, I'd rather have an adequate film. So if it means I have to use a phosphor plate and wait for that first image 6 or 7 seconds and then all the following ones 4 seconds, it doesn't make sense to, on time alone, base my decision to use a rigid sensor. And the length of time that you're gone from the operatory to process the x-rays is approximately a minute. If you did a full series using phosphor plate, your total time out of the operatory or your assistant's time out of the operatory is going to be roughly a minute and a half, under 2 minutes. So by the time you go back to the operatory, your radiographs are going to be on the screen and on the monitors that are in front of those patients that you're treating, that patient that you're treating. So I don't see where the time element is of significance in my mind. So let's look a bit about rigid sensors versus flexible sensors or phosphor plate technology. About 13% of our population, nearly 14%, do not use sensors at all. They're still analog users. 74% are using rigid sensors, and phosphor plate or flexible sensors are rapidly gaining in popularity, as they should be, because the answer is in this simple survey that was taken. If you look at the first bar on top, look at the percentage of patients that find the rigid sensors uncomfortable. The red bar is the rigid sensor, and the flexible or phosphor plate is the blue bar. Breakage is a big concern, as you see in the next bar graph. 6% of the population, of the dental population, worry about breakage. That's significant. Jump down, if you will, to the next circled one, where you see the question of cost. And the question of cost is one that we've got to take into consideration, because rigid sensors are far more expensive, and basically you also have to take an insurance policy against breakage on those rigid sensors. And I don't know about you, but these insurance policies very often are more than your car insurance, and the insurance just means that maybe you'll get it within 48 hours, that you'll get a replacement sensor. If my phosphor plate gets scratched or somebody bends it too much, I simply toss it out. A good sensor will run between $900 and $1,700, and a phosphor plate is probably $40 to $45. So not a big question in my mind, which is more affordable, which is more accessible to get hold of in a short period of time. And I think they are very much in favor when it comes to treating patients with tori. As you see moving down, patients with tori are uncomfortable almost 50% more of the time than using a flexible sensor. These are very, very quick to use. The integration on the software is excellent, and they are quite portable. There's no plugging into a USB port. And yes, I know there have been wired sensors. Wired sensors are even more bulky. I'm sorry, unwired sensors are even more bulky because they have to have a radio transmitter built into them. A wired sensor is bulky enough. A phosphor plate is actually the original unwired sensor. It's the original totally portable sensor. So I think that's a good choice. I think it's a good choice. Let's look at our dental population. Dental professionals find that rigid sensors were hard to place to get all the areas of the image. I would agree with that wholeheartedly. And more than half of our dental population said that the sensors pressing against tori are uncomfortable for many patients. Listen, I have a very big mouth, as you can hear from today and this presentation, and I have a big mouth in a lot of respects. But when it comes to trying sensors in my mouth, I tried nearly every one in the marketplace, and they were all uncomfortable. I found it was very gaggy when they were in my mouth, and the reason for that is you've got to put a protective covering over that rigid sensor, a poly bag, a sleeve. And when that's in the mouth and it's moving around with saliva, it created a gag reflex in myself as well as in many patients. The barrier sleeve, or the sterile barrier sleeve that you put on the phosphor plate when you expose it in the patient's mouth, does not cause that. Why? It feels the same as analog film did. So it's very, very comfortable. You know, Gordon Christensen, dear friend, looked at a lot of the rigid sensors and tried to equate them as to what he thought were good ones on the market. And there are very many good ones that are out there on the market for certain. If you look at this, by the way, I don't know if you can read it, but it's the September 2011 issue. And he just illustrated which sensors were out there. And, you know, he talked about the phosphor plate being very good. You see it here in the middle. And that is sort of unfair to compare it to all of these because I think a phosphor plate is rather unique. The disadvantage of a sensor is several-fold. Number one, that they are very thick. They're 4 to 8.5 millimeters without the cable compared to a phosphor plate, which is 0.34 millimeters. But in terms of the active area, and that translates to mean active capture area, what I think you need to know is you're only getting a maximum of maybe about 72%. So you're not getting to see everything that was on that radiograph. Too many areas are cut off. You'll need more images to take a complete view of the area because there's a smaller active area and you get cut off corners. It's also nearly impossible to take a complete image of a third molar using a rigid sensor, unless you're going down their esophagus at the same time. There is no dose reduction. The modern sensors need actually even a higher dose and get a smaller image. So if we're worried about how much radiation exposure we're going to provide to that patient, we certainly want to be conscientious and minimize the amount of radiation exposure. And therefore, by using a phosphor plate, we can very often reduce our exposure time as well as the amount of radiation that is necessary. So again, when he went through his summaries, he talked about sensor sizes, and a number 2 analog film, phosphor plate, or rigid sensor is typically the best one on the market. And the digital radiography is certainly the way to go. I mean, Gordon has advocated it for a long time, and I certainly stand right beside him when talking about that. So let's look at what is unique about the Air Technique ScanX system and their intraoral phosphor plates. First of all, 100% of that film is active. That means the entire film is your capture area. The entire film is your capture area, whether it's a 2, a 1, a 0, or even a number 4 film, an occlusal film, which I'll show you later. So you're basically going to get up to 38% more capture area. What are some of the other benefits that I alluded to earlier? There's no annual insurance policy. If I get, you can capture about 600 images on a phosphor plate just to make sure that I'm not overusing my phosphor plates. Every January, I throw them out and I start with 2 full series, about 40 plates of phosphor plates new every January, just to make sure. It's certainly, in doing that, much less costly than buying a sensor and having it break and taking an insurance policy. There's no doubt about it. So annual maintenance costs, very, very minimal. There's no need to change your practice management software, Dexis, SoftDent. Almost everybody will accommodate the phosphor plates for sure. And I think what's really key to this, even though it is very small down here, I'm very keen about improving my patient's experience. And if they can have a comfortable, good experience with minimized radiation, less radiographs that have to be taken, and when you're taking them, they're comfortable in the patient's mouth, to me, that's a win. That's an absolute win. So, are you still using film? Let's look at costs versus film cost. If you take an average of 50 x-rays a day, that means if you had 4 bite wings and 10 or 11 patients a day, you're going to spend about $330 a month if you amortize your cost of your ScanX machine and phosphor plate. The film cost per month using analog and chemicals is $1,786. I mean, you're talking something close to 6 times what you would spend. 6 times what you would spend. So you're saving about $1,500 a year, almost $4,000, a month, almost $4,000 a year. This is very, very economical to work with this. So you save time, you save money, you get unmatched patient comfort, and you have the ability to see your films very quick. So just to reiterate, why do I like phosphor plate? It's more comfortable for the patient. Remember what I said before? Faster, easier, better. Better for me, the dentist, but better for my patient, who is the ultimate end user. Whether you're the dentist taking the film, the hygienist, or the assistant, doesn't matter. It takes all intraoral sizes, 0 film, size 1, size 2, size 3, and the occlusal film, a size 4. It has a larger active image area, at least 25 to 38% greater capture area than the sensors on the market. You get high quality radiographic results. It's less than 7 seconds to scan a single first film, and probably about 4 seconds or less on every film thereafter that you're, so when you're processing a full series, you can do this in about 1.5 minutes. It's certainly more cost effective than traditional film. If you take into consideration the chemicals, the recycling of the chemicals, it makes no sense to have that in the office anymore. And it certainly is a perfect complement to rigid sensors, ensuring every image can be taken with complete comfort. So I think that you need to certainly give good thought to this. Let's look at image quality. As we see here, you're looking at a film that is going to be relative to what would be a minimal type of a full series. And what you're going to witness here is that look at the capture area and the minimal amount of loss of film that you're seeing, loss of image area on these films. You get full coverage. You can easily see the periodontal membrane, the root structure, the trabeculation in the bone, the inferior alveolar canal, all of this very easily witnessed on the digital film. And you can capture every image with ease, whether you're taking a, every image with ease, whether you're taking an endo size 1 film or even a size 2 film. This is a typical caries indicated bite wing that we would take. Here's your size 4 occlusal film. Nobody can do that with a rigid sensor. A size 3 is a long bite wing. I see this sometimes from periodontal offices. It's a film that I've used on occasion, but traditionally I stick to my, my size 2 phosphor plates. Pediatric films are good for endo also, and especially in the anterior. And these are cephalometric and panoramic films that were taken with conventional machine and processed on a they were taken with a phosphor plate on a traditional machine, but then became digital once we processed them in the ScanX Classic. So again, rigid sensors, look at the capture area that you're missing. You saw some of these in earlier pictures. You saw this in a square rigid one. This one that had basically told you what you were going to see because it already eliminated the sides. Just if you overlaid these, you'll see how much more of the same patient's teeth you can see. Patient comfort is very, very good. And by the time you go into the darkroom, you put them in a box, and I'll go over the mechanism for this in a moment, but when you go into the darkroom, you will see how easy it is. And this is what I said before, this picture on the right. When the patient is sitting like this and you place the x-ray, simply ask them to lift their feet and you'll notice the gag reflex is gone. I cannot explain that physiologically to you. Maybe it's just distracting their mind. I don't care what it is, it works, they don't gag, and it's amazing. And I've had that on children and adults and more mature adults as well. So the way that this system works is you expose the films in the treatment room. Let's say you're taking 4 bite wings. You would expose the films in the treatment room. The assistant or the hygienist will take the films. She would pull it, she will go into the dark room and take the phosphor plates out of their barrier sleeves and drop them into this phosphor plate transfer box. That transfer box will allow her now to deglove and place these films that are clean into the processor, in which she can now get a image scan, which will now scan the image. So certainly in the COVID times that we're experiencing now, sterility is key. We never want to have gloved hands that have touched an x-ray that might be moist with saliva. We want to debag it, if you will, or open the quick release on the, it's got a perforated top with a tear. You open it, drop it into the transfer box, then you can deglove and then handle the film in a sterile fashion. When we look at the image capture that we see here compared to a direct sensor, look at the image capture on the top series of radiographs and how we got the same information with less film. So where a full series using a direct sensor might be 18 to 20, you easily could do a full series with about 12, maybe 14 films. And you don't want to overlap. You don't want excessive radiation. You want to do it comfortably for the patient. So I think this is a very nice, easy depiction to show you what you can get using phosphor plate based on comparison against a digital or a direct sensor for sure. Now, let's take a look by comparison of a one-on-one versus the leading sensor on the marketplace today versus the Air Techniques Image 2. I think the picture certainly speaks for itself. Look how much larger this is, okay? The area of capture is everything that you see, as well as on this one, the direct sensor, your image capture area is only this small area inside. These areas here are being cut off, okay? So you're wasting a lot of time. And the film, when it's processed, shows you all of this as opposed to really getting only 3 teeth in this area, where in terms of full diagnostic capability, I've got 4 teeth in this one bite wing. 4 teeth in this one bite wing, where it would probably take me 2 bite wings to capture those 4 teeth using a direct sensor. So it may sound like I'm beating the bush, you know, in terms of, and beating a dead horse, but to me, I want to minimize my exposure time. I want to minimize my costs. I want to maximize my patient comfort. And that's what I'm doing by using phosphor plate. Some time ago, I had written a case study in Compendium. And I would ask you to, you can simply Google it. It was probably about a year or so ago that I wrote this. And I talked about everything I'm talking about tonight. In the demonstration here, I was showing how I needed a quick film, and I used the Swift without the viewer. And because by the time you put it in the Swift and turn around, the image was just about on my screen. It's a very fast, or pardon the pun, Swift processor. And I use it for endodontic evaluation and oral surgery, implant placement, things like that. But the 2 main points I made in this article was the patient you see on the upper left little box, the regular photograph, had parotid cancer about 25 years ago, had parotid gland cancer. In those days, they anastomosed the area, and so it totally restricted his ability to open. And you explained to me how I'm going to get a rigid sensor into this patient's mouth, as opposed to, as we all know, with a regular analog film, I'd be able to flex it, bend it, slip it in, and have him use his finger or a positioning device like a RIN or an alligator bite positioner. Any of those can be used very comfortably with analog film. Well, guess what? Digital film works exactly the same way. And because of that, I was able to capture the images that you see on this patient and thereby be able to adequately diagnose his problem and then fully be able to treat him in the manner I would anyone who had a normal opening. Another case I showed and demonstrated was rather grossly large mandibular bilateral tori. And again, a rigid sensor, there's no way you'd capture these film. There's no way you'd capture those anteriors because you couldn't get it in close enough to get a clear, crisp image capture, and it would cut off all the corners. Well, here you see, by using my phosphor plate and placing that in and curving it because it's flexible, I was easily able to capture the anterior teeth in the front. And just the other day, I had another patient, and I just wanted to show you how here, these are undoctored. I don't like to doctor my film at all. So here you see a bilateral tori, but one that's more prominent on the lower right side, and how we simply place it with a patient holding it, in this case, against their mouth because they have a rather narrow mouth, and we can have them take that film and capture it easily for me. And just another view on the other side, very easily with a gloved finger, the patient is putting it in. And we provide gloves for the patients, obviously, before and during this COVID time. But again, take a look at what you're capturing here. This is just a depiction of, again, what the sensors, the various ones on the market that are out there, can afford you, how large these are compared to 2.9 by 3.9. We get up in that area with a 1 film, but most of the time you're using a 2 film. And the 2 film is the most common. You will get 3 to 4 teeth, as you see here, 4 teeth comfortably each and every time. So your diagnosis is very, very good, very easy to use, okay? Here you see the plate image, again, using a square sensor, one that doesn't have edges cut off. But again, even with the square sensor, look how little you are capturing. You're missing the first bicuspid. Well, my number 2 film with the phosphor plate did not miss that first bicuspid. So it captured it very nice and very easy. Next, we have digital radiography, again showing you another capture of using rigid sensor, and again versus the phosphor plate. And you can see the phosphor plate, frankly, wins every time. It wins every time, because I never want to lose anything that I can possibly see on a radiograph. That is the only way we can truly diagnose, is if we capture the entire image each and every time. Now, there are certain things that you can do by using the programs that you have in your systems, and the one that comes, the Vista Easy system, has a few different modes that are built in. They have intrafine, caries detection, endo, perio, and high diagnostic. Let's take a look at what that means. First of all, if you put the high diagnostic filter on, you notice how your image becomes immediately more clear to you, a higher degree of clarity. It's more readable. You can see more detail to the tooth. And that's done with automatic by clicking on the diagnostic filter, and you don't have to fiddle with the x-ray like you might have had to if you used a system that didn't have a filter like that built in. If we go to the caries filter, it too works very similar to the previous filter of high diagnostic filter, but again, this illuminates no rings, the rings we put on, but it illuminates where the caries is very clear and makes it a very clear, crisp diagnostic film. The endo filter, again, is sort of like a specific high diagnostic filter that can be used when you're doing endodontics. And you see the brilliance of the film on the right when you're using the endodontic filter. So this is a very, very key feature that I find. Now, this to me is probably one of the most underutilized filters and abilities we have with our digital film processing, and it's called the inversion filter. Very often when you're looking in a cracked tooth, well, a suspected cracked tooth syndrome, or a patient has injured their tooth traumatically, you will be looking for fractures, you will be looking for microfractures, and you will be looking for, in endodontic therapy, sometimes accessory canals. If you take your conventional standard view on the left and use the inversion filter, which converts black to white, and you will see more diagnostically the canals, you'll see more diagnostically any fractures, any accessory canals, and to me, I use this feature almost daily when I'm diagnosing patients with specific problems. So the inversion filter to me is an absolute necessity, and one that makes the whole value of using digital radiography come to real fruition in my mind and make it easy to understand. So just to go over a few couple of things that I think are important to understand. There's a certain reason why there's a thickness to those hard rigid sensors. They have a rigid plastic casing. They have the built-in electronics in them that adds in bulk. They are much thicker because of all the mechanics that have to be placed in it. Whereas a phosphor plate is flexible. It's just that ionic layer that's needed to store the radiograph. It's 30 times thinner. It's a wireless adapter. It is a patient-friendly device that will go from a 0 film all the way up to a size 4. It's used in any possible situation, certainly patients with large tori, gag reflex, easy to use it, much more comfortable for the patient, and to me, unmatched patient comfort, and that was the win in my mind. So the product benefits: 17% to 38% more capture area on 100% of your radiographs, complete coronal apical length, full mesial distal information, never miss a root tip or a cusp, fewer retakes, fewer radiation, less radiation exposure, okay? These are 30 times thinner than rigid sensor, easier to position for taking your radiographs of posterior teeth, and less gag induced to the patients, and the patients can fully close their mouth to maintain occlusion when you're taking a bite wing. So I think that is critical. 100% active area, no cutoffs at the edges, as you see here. In occlusion, you can get a nice film easily of them being able to close their mouth, and no problem in reading this at all. So, thin and flexible, increased patient comfort, ease of use, all the sizes possible, including the number 4 occlusal film. The largest active image area of any radiograph in the market is the phosphor plate. High quality diagnostic radiographs, up to 20 IP per millimeter, fast acquisition. The difference between 2 seconds and 4 seconds is 2 seconds. I'd sacrifice the 2 seconds any day of the week to get all of these things that I've just talked to you about. They're highly cost effective, no maintenance contracts, replaceable. If you scratch them, you just buy a new plate, and it's certainly the perfect complement to any practice currently using hard centers. So I want to thank you, and I think we are going to open this up now to questions, and see if there are any questions out there. And I've got a few, and let me talk to you a little bit. Let's answer this great question. Is the insurance cost for wired sensors expensive? I think in my mind it's prohibitively expensive. I've heard fees from $900 to $1,700 annually. I don't think that that is something that I really want to spend. Listen, we're all going through a tough time now. We're spending a lot of money on PPE. I think that that's better spent money. How many uses can I expect to get from a phosphor plate? Good question. These are great questions. Certainly, I think, you know, getting about 600 from a single plate is not unreasonable. Again, I said I don't sit there and count or mark how many times I've used a specific plate. I simply, every January, throw them out and go ahead and buy a couple of full series, about 40 films, 40 new plates, and I start the year fresh and with clean slate and a clean plate, if you will, and I have no problem doing that. And, you know, if you're buying them at 40 of them times, let's say $45 times 40, you're spending, you know, not a lot of money at all. You're spending about $1,800. That's what the cost of an annual contract would cost, perhaps, or if you had to go out and buy a new sensor. So I don't think that's prohibitive in my mind. Yes, how do phosphor plates, how do they get disinfected? Well, Air Techniques makes a great line, the Monarch line of disinfectants that you can use in your office, from counter wipes to disinfectants for hand sanitizing, to those you use in the ultrasonic cleaning, to line cleaners. I think these are all excellent ones that you can look at, the Monarch line. But specific to phosphor plates, they make a, looks like a wipe cloth that comes in a tear open package, and you simply open it and wipe all your phosphor plates with it. Does the phosphor plate scanner require any special maintenance? No, it doesn't. I've not found that. Have you found that insurance carriers are able to settle cases easier that I have a digital device? Oh, yes, much, much easier. And if you're using digital and you're transmitting your claims electronically, you can attach a digital film to most of your claims, and that will accelerate your processing time by the insurance carrier and eliminate them having to ask you to mail in a hard copy film. Did I see a return on investment in the first year of purchasing my unit? Absolutely. I had not only a return on investment, I had a happier staff, and they were easily and quickly to adapt to the use of the digital radiography because they saw how patients like it, but they liked the fact there wasn't any chemical smell. They didn't have to change the tanks. They didn't have to use a processing unit like the PeriPro or something, and then they still had tanks they had to process. So I don't think that it's something that we really want to really have to consider. Another good question, how durable is the ScanX machine, including expense-wise? It's Air Techniques. I don't think most of the dentists in the United States, in my mind, have Air Techniques compressors, and they last forever. They're workhorses. Well, you know what? They built the same quality in their phosphor plate processors. These are workhorse machines, and I don't think you need to be worried whatsoever. So I want to thank you all for joining me this evening. If there are no more questions, I appreciate your time. I'd appreciate your consideration in looking at Air Techniques phosphor plate technology, the ScanX system, and thank you on behalf of your patients for considering converting to the wonderful world of digital radiography using phosphor plate technology. Thank you all for attending this evening.